Hello, my name is Kate Chesterman. I'm a GP in South Norfolk, and I also co-host the GPnotebook education study groups. Welcome to the current season of GPnotebook podcasts, where we present bite-sized topics aimed at all those working in primary care. You can follow me on Twitter @ChestermanKate for more information about the new podcasts and study groups as they become available. Now, for the next few episodes of the podcast, we've got something a little different for you. In May 2022, as part of something we're calling Chronic Conditions Month, there is a series of 7 webinars with live Q&A sessions, each focusing on a different long-term condition. The webinars, which are being run in association with GPnotebook, are designed to provide wide-ranging clinical education programme, focusing not only on the diagnosis and management of different chronic conditions, but also on the strategies required to address the complex and challenging interplay between coexisting morbidities. Healthcare professionals in the UK can register to attend all the events for free at www.chronicconditions.co.uk, so I hope you'll be interested in joining. And to accompany the webinars, the Chronic Conditions faculty has recorded a series of podcasts in the past few weeks, in which they provide some practical advice and suggestions to help you optimise care here and now across a range of conditions. So, without further delay, please enjoy the second in this series of special episodes. This one is brought to you by Dr Steve Holmes and Dr Yassir Javaid, who are discussing the overlap between COPD and heart disease.
Hello, I'm Yassir Javaid and welcome to this podcast. I'm a GP with a specialist interest in cardiology based in Northampton, and I'm joined today by a very good friend and colleague, Dr Steve Holmes, who's a GP with a huge passion and long-standing interest in respiratory medicine. He's based in Somerset. And this podcast comes to you as part of Chronic Conditions Month 2022, which is taking place throughout the month of May. It will include a whole string of interactive and informative webinars designed to address the primary care challenges of diagnosing and managing chronic conditions across a range of therapeutic areas. And today, in this podcast, we're going to be discussing a very important connection, the heart-lung connection, and more specifically, this overlap between chronic obstructive pulmonary disease and heart disease. So, Steve, very often patients with heart and lung disease will present with breathlessness or a subtle reduction in effort tolerance. Give us a flavour for how straightforward it can be to make a diagnosis, establish a diagnosis of COPD.
Hi, Yassir. Great to see you again, and hello everybody listening in. Yes, if we're practical clinicians, the first thing is it's very easy to look at a guideline and see a nice clear-cut, absolutely barn door situation that we look for. And sometimes it's easy, but a lot of times there's a lot of shades of between white and black, 50 shades of grey. And that sort of 50 shades in real clinical practice means we always have to be applying our clinical acumen. If I just probably talk through the typical person with COPD, and then perhaps, Yassir, you talk about the similarities. But your typical person with COPD will normally be diagnosed around the age of 65. Quite a few are younger when they're diagnosed, and think in that situation we're thinking about other things other than smoking, possibly cannabis or other substances. But 90% of them have a smoking history. If we're looking at examination, they won't have some of the things that Yassir will talk about, the cardiac problems, the murmurs, the irregular heart rates, or they might do. And at times when they're symptomatic, they'll be wheezy. They will often have a cough, breathlessness, ongoing, gradually reducing the amount they can do. And what we tend to do to make a good diagnosis of COPD is think full blood count, make sure they're not anemic, consider the other causes, make sure they've had a chest x-ray so you're not embarrassed by lung cancer or something else like that, and high quality spirometry.
Brilliant. Well, that's a fairly straightforward sort of diagnostic workup, isn't it, of a patient with suspected COPD. So I guess for the typical heart failure patient that I see, actually many of them don't present with breathlessness. A lot of them are going to present with a sort of reduction in effort tolerance. So these are patients who maybe be putting these symptoms down to normal aging, but there's something there that's concerning them in relation to not being able to do as much as they used to, whether it's gardening, whether it's walking up that slight incline to the shops. And in these patients, you'll take a history not just of the breathlessness, but also any associated symptoms. And in heart failure, you very often get symptoms of congestion, and that's well worth asking about. And also typically, be interesting to hear your thoughts on what happens with COPD, but typically the breathlessness in a heart failure patient does get significantly worse when you lie flat. What happens? Is there any positional relation to breathlessness in COPD, Steve?
Again, the typical person tends not to have breathlessness when they lie flat and not to wake up at night breathless in typical COPD. And they tend to present with quite a few exacerbations. So one thing that's interesting is that before diagnosis, most patients have turned up 5 to 6 times for their diagnosis of COPD. I guess that's probably going to be true of quite a few patients with heart failure. And one thing that struck me was that in COPD, the average age of diagnosis is 64. Hasn't changed for 20 years. 2 years ago, when I looked at a review, heart failure average age of diagnosis 74. Hasn't changed for 20 years. We're not picking these people up earlier for some reason.
No, we're not. And we're almost waiting for the patient to present with quite significant symptoms when actually we've probably missed the subtle decline in that effort tolerance. I mean, in the history, obviously, just like in COPD, a smoking history is very crucial. And these are shared sort of cardiorespiratory risk factors often. Alcohol, I never forget to ask about an alcohol history in a patient who potentially has suspected heart failure. We do often miss the alcoholic cardiomyopathy, and we have to tease that out of many patients. And one bit of the history that I'll never forget to ask, particularly a youngish patient who may not fit the typical bill of a patient with heart failure, is any exposure to chemotherapy, particularly anthracycline chemotherapy. So these are patients who've had maybe pediatric leukemias or breast cancer at a young age. We know there can be a decade's worth of delay in terms of damage to the myocardium and presenting with heart failure. But the typical risk factors would be hypertension and ischemic heart disease. I mean, ischemic heart disease is the cause for around half to 2/3 of patients with reduced ejection heart failure in this country. So it's important to pick up patients with that history. What about examination, Steve? Any particular pointers on examination that would make you home in on a respiratory rather than a cardiovascular cause?
You often talk about variable wheeze, but it doesn't have to be there. I think often the examination is exclusion of different issues. The other thing that a lot of us will be doing is peak flows when we get back to doing that after the pandemic. And usually the peak flow is about 1/3 of normal and remains static throughout. But I agree with you. I think one of the real challenges is that history. It's gradual onset. And one of our colleagues, Hilary Pinnock, who's professor in Edinburgh and a GP in Kent, manage that one if you can, actually had a lovely story about published in the BMJ, which talked about things like heart failure and COPD being a way of life, not an event. If you have a crushing central chest pain and a heart attack, everyone knows when that happened. People know when they suddenly lost blood from their bowel or noticed a lump in their breast. But for people with heart failure and COPD, it's often a gradual deterioration. They can't quite keep up with their grandchildren as quickly or their friends. And that makes it much more challenging for us in the clinical situation because they see it as a way of life.
Absolutely. And often they adapt their lifestyle to suit their underlying diagnosis, to almost make them asymptomatic. And I think that's when it's helpful to maybe ask, husband, wife, children, that they often will notice that, especially if they don't see them, I see my dad maybe every couple of months, and I'll probably notice the decline more than he would if it was a sort of a more insidious onset. I think in heart failure in particular, there are probably more objective signs that you can identify. Difficult to find signs often. I mean, a raised JVP, notoriously difficult sign to find, particularly in primary care. But if you do see someone with a JVP up to the earlobes, that's a sign of quite significant right atrial pressure and congestion. Pulmonary edema, so fluid in the base of the lungs. We can often hear those fine inspiratory crepitations. Heart sounds, I think, are absolutely critical. We need to make sure we're not missing the aortic stenosis. You could argue part of the normal aging process, but the most preventable cause of heart failure. And clearly the pulse. I mean, atrial fibrillation is, I call it the heart failure mimic. It can cause the same symptoms, similar signs, and also is a cause and effect of heart failure. But Steve, the one sign I really don't want to miss, particularly my 75-year-old slightly breathless patient, is finger clubbing. Because for me, finger clubbing is a sign of perhaps homing in on a likely respiratory underlying cause, particularly the pulmonary fibrosis. I mean, patients with cystic fibrosis, the classic cause of finger clubbing, often don't live long enough to present at the age of 75. I mean, I've never seen that, but clubbing for me just changes the flavour of that differential diagnosis.
Yeah, and I think if you spot clubbing, first of all, urgent chest x-ray. One of the commonest reasons is lung cancer. It can be an evidence of chronic ongoing inflammation, so that's your sort of bronchiectasis or at times the interstitial lung diseases. It's very, very rare in COPD. So if you're making a diagnosis of COPD on the basis of clubbing, it really is worthwhile thinking again. And you probably, like me, when you listen in, you sometimes get a shock. You hear a very large pleural effusion. What unilateral? Think cancer. Bilateral? Think potentially cardiac or occasionally nephrotic stroke liver. But it is important to get the stethoscope out still. It's not a redundant bit of kit that we bought at medical school.
No, it is. Well, I'm slightly biased. I think it's a critical part of the assessment. As I said, the most important thing not to miss is that systolic murmur. It's usually very obvious, second intercostal space, right sternal edge. If you hear a systolic murmur, and if you start getting familiar with murmurs and you realise that second heart sound is becoming a bit soft, that's a sign of quite critical aortic stenosis. And these patients now, if we can refer them in a timely fashion, in a TAVI, transcatheter aortic valve implantation, is a very viable alternative to surgery, can actually almost normalise your life expectancy. But I totally agree with you, Steve. One of the big red flags for me is making sure I don't miss small cell carcinoma of the lung. And absolutely, if you're finger clubbing, you go straight for an urgent x-ray. Other investigations I'd be looking to do fairly early on if I suspected a cardiac cause would obviously be an ECG. I mean, a 12-lead ECG is an incredibly good screen for ruling out anything significant from a cardiac perspective. A completely normal ECG. Obviously, it's going to pick up the atrial fibrillation. You're going to see things like left bundle branch block, which are very commonly found in significant structural heart disease. But we're lucky, Steve, in cardiology. I think we have the best screening test in medicine. We've got a blood test, a hormone, NT-proBNP, which is released by the myocardium, predominantly but not exclusively the left ventricular myocardium in response to stretch. And it has almost 100% negative predictive value for significant heart failure. So, but the other test that you don't want to miss, I don't know if you see this a lot, Steve, we still see a lot of patients referred for query heart failure simply because we haven't done the basics and we haven't ruled out the underlying colonic malignancy when we find a hemoglobin of 5.4.
Yeah, no, I've seen a few of those over time as well. The person who comes in to see you and you think, they look very, very pale. And it's other reasons behind the symptoms they're getting. Yeah, no, I agree. And I guess probably one of the things that a lot of colleagues would ask about, and certainly a lot of my nurse colleagues who are very keen to try and pick up diagnoses earlier, often say, is it worthwhile doing a chest x-ray every year in someone with COPD? And I think there isn't the evidence there for that, and we accept that now. But quite a few people are starting to say, should we be doing a screening pro-BNP every year just to see whether things are deteriorating, knowing that those comorbidities can coexist so commonly? I don't know if you're aware of anything on that at the moment.
Yeah, I mean, it can be useful. I mean, I use NT-proBNP essentially if you really want to simplify what an NT-proBNP does, it helps you very much differentiate cardiac versus non-cardiac causes of breathlessness. So I use it a lot in valve disease. As patients get older, they get a bit deconditioned. You don't know whether their worsening breathlessness is due to their deterioration of their valve disease or whether it's just age-related deconditioning. Then an NT-proBNP is very helpful. But I think to use it serially in a patient whose symptoms haven't changed, that's certainly not guideline recommended. And I think it possibly could open up a can of worms because there's lots of other causes of an elevated NT-proBNP, including age, which could end up meaning you do a lot more echocardiograms than you otherwise would.
That fits in with the term vomit, victim of medical imaging and technology, where we start testing and then end up pushing people down roads that create anxiety and sometimes quite a lot of harm if you get into the situation of biopsying lung nodules or things like that. So, yes, the Americans are keen on that at the moment. I'm not so keen on vomit.
I haven't heard of that acronym, but it's I completely agree with with that concept. But Steve, before we finish, we mustn't forget though that many patients with COPD, and dare I say it, well, I know many patients with heart failure, often have other causes for their breathlessness that contributes to their symptoms. And we know that COPD and heart failure have a huge overlap. In fact, I've read in some studies, almost 50% of COPD patients have an element of heart failure. So, we mustn't fall into the trap of once we've given a patient a label of one of these conditions to forget to hunt for the other sort of exacerbating causes. I mean, do you see that a lot in your respiratory work?
Yes, certainly I see a lot of overlap with patients who've had COPD for a long time developing heart failure. I think one of the things that stands out to me that's an important message about smoking is about 20% of people who smoke will develop COPD in their lifetime, but the other 80% don't. And that's important to recognise because there's a lot of people say, well, you've smoked and you've got a cough, therefore it must be COPD. We do need to go through the whole pathway to make that diagnosis. I think that's really important. But I think the other thing is when you feel breathless or tired, you don't want to exert. And that puts you into that horrible cycle of less activity. And when you are active, you feel more tired and you feel more breathless. And really, to me, that's one of the fundamental parts why we have cardiac rehab and pulmonary rehab, and why we should be really pushing forward the agenda of getting people to use their hearts and lungs to their maximum to get the best benefit from it.
Well, on that point, Steve, I mean, we've gone through, unique times in the last couple of years, lockdown. There must be, patients, a lot of our patients have become more sedentary. Tell us about how deconditioning can contribute to the sort of symptomology of these patients.
Right. I think the first thing is to reflect yourself. If you're used to biking 60 kilometres or running 20 kilometres, and then you try and do twice that distance quickly or quicker, you find you get breathless. If you're not used to running or biking those distances and you try and do it, you feel absolutely shattered. That's because your lungs aren't getting used to it, but you can train yourself up for that. And most people can train themselves up to get more out of the system than they're currently using. I guess one of the things is in COVID, we were saying, stay home, stay safe, and you're only allowed to go out and exercise for half an hour or whatever it was a day, which actually gave all the wrong messages. And although we had Joe Wicks for a certain age group, a lot of people who were more senior, there was no great push from the government to ensure they maintain fitness. What does deconditioning do? Well, it makes you more likely to have a heart attack, makes you more likely to be symptomatic when you exert yourself, it makes you more likely to falls, diabetes, hypertension, the list goes on and on, osteoporosis. We've got a major problem on our hands with the lack of activity of our population at the moment.
Yeah, no, I think that's such an important point, and that's why we've got to be sort of very holistic in our assessments of these patients. Just a couple of specific points for me, sort of tips that I think are very handy when you're assessing patients, particularly ones who you feel have more of a cardiac cause. I'm always hunting for COPD in my heart failure patients with a smoking history, and a big clue is when you get the echocardiogram, which all suspected heart failure patient should have. Always look at the right ventricular systolic pressure. Every echocardiogram has to report on this. It's, an echocardiogram is a lot more than an ejection fraction. And if you start seeing pulmonary pressures more than 46 millimeters of mercury, think potentially a cardiac sort of comorbidity with their heart failure. The other issue that I want to address is I'm still sadly seeing a lot of patients being denied probably the most effective treatment we have in heart failure, beta blockers, simply because they've got a diagnosis of COPD. Steve, just reassure us, if someone hasn't got significant reversibility on spirometry, I mean, beta blockers are completely safe in these patients.
We're on the same page. I agree with you thoroughly. We can use beta blockers in people with COPD. That's been the case for a long period of time.
Yep. And then finally, slightly as an aside, looking at this cardiorespiratory link, obstructive sleep apnea for me and in cardiology has become such an important risk factor. We know it's a huge driver for a particular form of heart failure known as heart failure with preserved ejection fraction. So always think of that as part of your differential in a patient who's also got risk factors for obstructive sleep apnea. Plus, it increases your risk of developing atrial fibrillation sevenfold. So anyone with obstructive sleep apnea should get a pulse check, in my opinion, on when they're reviewed. So
I would agree, and I think certainly in COPD we should be thinking about a pulse check every year. I think in heart failure, the evidence for screening every patient every year probably isn't quite as good at the moment. But if you do a peak flow and that level is down, that should make you start to think, actually, is there an element of obstructive lung disease there as well?
Fantastic. Steve, can I just say it's been an absolute pleasure to interact. I think we've had a really good cardiorespiratory collaboration, and I very much hope members of the audience also found this helpful. So thank you very much, Steve, for your time.
And thanks for your expertise, Yassir, and I hope our audience enjoyed it. There are more to come.
Thank you. Yeah, so thank you very much for listening. We, as I hope you find this whole series useful, so please do look on the website. Make sure you register on that Chronic Conditions website so you can listen to all the other podcasts in this series, and also for our interactive webcasts brought to you as part of Chronic Conditions Month 2022. So you can sign up at chronicconditions.co.uk.